uh, substance use program of research guest speaker series. And it is my great pleasure to introduce today's guest, Dr. Steffani Strathdee, who is an Associate Dean of Global Health Sciences and Harold Simon Distinguished Professor of Medicine at the University of California, San Diego. Dr. Strathdee has studied the syndemics of HIV, viral hepatitis, TB, and sexually transmitted infections among substance users internationally, and especially in the Mexico-US border for over 20 years. And she has published over 700 manuscripts. Dr. Strathdee was named one of Time Magazine's most influential people in healthcare in 2018 and was listed on the top half of the best female scientists in the world in 2022. On a personal level, Dr. Strathdee is also one of my mentors in the HIV Prevention Trials Network's Substance Use Scientific Committee. She has consistently demonstrated a genuine commitment to supporting early career investigators in HIV and substance use research, including investigators here at UCSF. In fact, she's even served as a guest speaker for the UCSF Traineeship in AIDS Prevention Studies, or TAPS Fellowship. So she has definitely been a big part of our UCSF family, and we are grateful that she is joining us today. So everybody, please give Dr. Strathdee a warm UCSF welcome.
Thank you so much. It's wonderful to be here, and I wish I could be there in person, but virtually is almost as good. So lots of familiar faces, not just from mentees that I knew from San Diego, but even back to Baltimore days. So very exciting. So I'm going to share with you some of the lessons that I've personally taken away from research that I've been doing on the Mexico-US border for the last 20 years, focusing first on HIV and then expanding to related syndemics. And I have to say that when I first arrived in San Diego, I didn't know what a syndemic was. That was like 2004, and quickly realized that there's a lot of overlapping epidemics with similar root causes. And we'll be talking about that today. So just to orient folks a little bit, this is the Tijuana River Canal. Right now it's full of water because we've had so much rain, but most of the time it looks like this. It's a dry riverbed, and you'll see that the side that the US is on is a big fence, and yet that line, that painted line, really represents one of the border crossings, and this one is not policed very well. And also on the left-hand side of this screen is an open sewer. And when I first arrived to do work in Mexico, I was shocked that people were actually living in these sewers. And we gave people a disposable camera to kind of chronicle their lives so that we could get a better understanding, as nobody had done work with this population in this way before. And the pictures that came back were really shocking, that folks were, living in really destitute conditions, totally unhoused, open defecation, using sewer water to clean their syringes, etc. Later on, a colleague of mine, John Cohen, who writes for Science Magazine, along with a photographer, Malcolm Linton, wrote a book. It's really a photo ethnographic book called Tomorrow is a Long Time. And some of the photos that I'm going to show you were taken by Malcolm. So this is a woman, her nickname is China. She lives in the Tijuana River Canal. And as you can see, she's preparing her drugs for injection. And China, not unlike many others who are practicing sex work in the nearby region, this is an area where sex work is quasi-legal, but people who inject drugs and those who are HIV positive often don't get access to permits because of discrimination and stigma, and so it really drives people underground and leads these folks to engage in higher risk behaviors. So one of the first lessons I really learned in this region when I started to to do work is that how important equity matters in terms of ensuring that our Mexican colleagues get equal say, and that they also learn about the results before they get published. So one of the things that I experienced kind of just by associating with UCSD was that another researcher had presented some results at a conference on HIV in pregnant women, and that found itself on the front page of the newspaper the next day. And the health minister didn't even know about the results. So that really blew back on UCSD for a while, and it made it more difficult for us to engage in research, even though it wasn't research that I was involved in any way. We all represent the university. And so when, mistakes are made, it affects all of us. So what we did was we came up with some guiding principles that every project has a PI from both UCSD and Mexico, that every manuscript or presentation has at least one Mexican co-author. And if there's multiple sites, one co-author per site, and that findings are shared with Mexican health authorities before presentation or publication, and that any press releases are carefully coordinated with spokespersons on both sides of the border and are available in Spanish and English. So this has served me and my colleagues well, and we actually include these guiding principles in our NIH grant proposals when it comes to data sharing, so that we're upholding what we commit to the NIH. One of the earlier papers that we engaged in was based on actually it was CFAR data that allowed us to do prevalence and correlates of HIV infection among people who inject drugs in Tijuana and Ciudad Juarez. And my colleague Rebecca Ramos published this paper in Health in Place. And it really, shed a light on the high-risk behaviors that these folks were engaging in. So picaderos are slang for shooting galleries, and in Tijuana, over half of people who inject drugs were injecting in these locations. A quarter were mostly injecting outside. A third were often always using borrowed, bought, or rented syringes. And a much higher proportion in Tijuana had ever been arrested for carrying used syringes. And this is despite the fact that actually it was legal to carry syringes without a prescription in Tijuana. And yet police didn't seem to know that, and either did the people who inject drugs. So this was something that I remembered much later, and you'll see that it informed the development of an intervention. And then ever injecting in jail was also a big problem. And this led Rebecca to begin a syringe exchange program in the jail setting in Ciudad Juarez. We were not able to do that in Tijuana, but these data informed a subsequent cohort study that I wrote and was funded in 2004. And so that began a very long set of binational studies. We also looked at HIV, syphilis, Hep C, and in Ciudad Juarez, we had a donation for hepatitis B core testing. And HIV prevalence was extremely low. This was in 2005. However, syphilis prevalence was much higher, and Hep C was almost saturated. And we published one of these papers in Salud Pública, Mexico, which is the leading public health journal in Mexico on the Hep C data, because we really wanted to bring attention to this problem. And it was on the Secretary of Health's desk the very next day. In fact, he contacted me and asked whether or not there was a mistake and whether it could have been false positives in the data. And I said, no, these were done by, the testing was done at the health department. And, these are, cases that true infections, but we of course didn't know to what extent, there were active infections at the time, because we didn't have the ability to test for HCV RNA. But nevertheless, these data, they weren't a surprise to those of us that have studied hepatitis C in other settings, but it was a surprise for Mexico. So sometimes publishing in the country that you're working in, whether, and using the language of that country is important, because if we just publish this in an English journal, it might have been buried. And so at least it got on the radar. We went on and conducted HIV prevalence studies among many different subpopulations in Tijuana. I include the data from the pregnant women, although that was not conducted by my team. But you can see that pregnant women had an HIV prevalence of 1%, and those that were substance users, it was 6%. The female sex workers, the overall prevalence was only 6%, but if you look at female sex workers that inject drugs, it was up to 12%. And of course, not surprisingly, men who are having sex with men had a prevalence of 15%. So these data were actually important because these were some of the first estimates of HIV prevalence in the country. And this was restricted to the northern border region, obviously, but it was helpful for us to be able to decide where we were going to try to intervene. And we decided that it was important to draw attention to these data because there were such limited resources being made available to these populations. So what we did was we took this bar chart of HIV prevalence in the Americas, which has Haiti on the top and Bolivia on the bottom, and Mexico as a country is near the bottom, and that's that red bar and near the bottom. And Tijuana, you can see, is even higher than the United States. And so we did some estimates of the number of HIV positive people in these risk groups as well. And we published those data. That was published by one of my PhD students, Esmeralda Iniguez. And we also took the opportunity to write an op-ed that was published in JAMA, coinciding with the International AIDS Conference that was held in Mexico in 2012. And that led to, attention in a major way. We issued a press release in English and Spanish. My colleague, Dr. Rangel at the Mexico-U.S. Border Health Commission was a spokesperson. And this was even covered on CNN. And so finally, we were getting some resources coming into the city for harm reduction. And it was too little, too late, but it was important that we do this. And these kinds of press releases are really delicate, depending on the binational relations, because we really wanted to avoid one country blaming the other for their infections. So on that note, that leads me to the second lesson, which is that infectious diseases don't have passports, and also that the dynamics of these cross-border transmission can change quite quickly. So here's some data that was done by my colleagues, Sanjay Mehta and Antoine Chaon. And this one was published in 2015. They used a molecular clock and they did subtyping of all of the HIV positive samples that we had obtained and compared them to a repository of sequences from San Diego. And what they found was that early on in the HIV epidemic, that most of the infections originated in the US and ended up in Tijuana because people were coming across the border for work and then going back home. And sometimes they took HIV with them. But in more recent years, you can see in the line in red that it's been the other way around, that we have cases of HIV in Tijuana, many of whom are not being treated due to lack of resources. And we'll talk about that later. And that those that cross-border transmission, there's drug tourism, there's sex tourism, and that people are often bringing these infections back to the US. So this is a binational problem. It's a shared problem. And it's one that if we are going to try to end the HIV epidemic in the US, we have to include the border region. We also assessed the overlapping risk populations because generally, our field has tended to look at people in silos and not look at the fact that there are people who are engaging in multiple behaviors. And so you can see that there's quite a bit of overlap. And then we also have examined not just HIV, but sexually transmitted infections. And here we're reporting on the prevalence of HIV and syphilis. And as you can see, this is lifetime syphilis here, but the prevalence is extremely high. And then when we look at the titers of syphilis cases that are above 1 to 8, which are suggestive of active infections in the absence of treatment. And I can tell you that because syphilis is not a reportable condition in Mexico, that contact tracing is not possible. So, most of these cases have never been treated. So roughly half of all of these cases that we identified had syphilis titers above 1 to 8, which, obviously is going to, not just affect, the people that have it, but can lead to congenital syphilis among neonates, and also that syphilis is a cofactor for HIV transmission. And that's exactly what we found when we did a study of female sex workers. This was actually done by my husband, Tom. He found that not just injection and non-injection drug use behaviors were independently associated with HIV, but so was active syphilis. And this was a surprise to him because he was expecting to see high-risk sexual behaviors associated with HIV, but largely the substance-using behaviors had been overlooked in the region, and we started to work actively together on this. We also shared these results, of course, with the health department. And then when we examined more closely, some of the subsets of sex workers were at a special risk, and that this economic situation between the differences between the US and Mexico are a major driving factor, because 70% of the female sex workers in both of these cities have US clients. And when we looked at those that had US clients, they were more likely to engage in higher risk behaviors. They were more likely to have syphilis titers that were active, for example, and to inject drugs, have high client volumes. And they were also the same women who were being paid more for having unprotected sex. So we put out an alert around this because we wanted clients to be aware that if they're offering people more money for unprotected sex, and they're asking that sex worker to put a price on their health, and that if the person is addicted to drugs, it makes it even harder because they've got that addiction to feed, and they probably have children at home to feed as well. So it really undermines our efforts in HIV prevention. My husband, Tom, went on to do a randomized controlled study to try to increase condom use among sex workers in both Tijuana and CFAR. And it was theory-based. It was a brief intervention training peers to deliver a motivational intervention to help them troubleshoot condom use. And it involved 450 female sex workers in both of these cities. And the results were pretty astonishing, and that there was a significant reduction in both HIV and STI incidents. But one of the things that we noticed is that the women who didn't change their behaviors were those that were more likely to be injecting drugs. And that's because this intervention wasn't designed to take into account substance use within the context of sex work. It's probably because I hadn't arrived in San Diego yet, and when I did, things rapidly changed because we realized that this is a big problem. So I decided to ask Tom, I said, why don't we redesign this intervention and adapt it to incorporate sex work that is in the context of drug use, to see if we can, change this this set of conditions for these women. And initially had this idea that I could take this intervention that we had developed in the US called the Do It study, and this and another one called the Strive study, that had developed a video to show people how their drug injection equipment can become contaminated. And this leads to a lesson that I learned about one size not fitting all with interventions, that they need cultural and linguistic adaptations. Let me show you what I mean by that. So this was a still from the video that was developed by the CDC. And it starts out by hi, my name is Cindy. I'm going to show you how your injection equipment can become contaminated with HIV or Hep C, even if you don't share a syringe. So the idea behind this video was really ingenious. My colleague Richard Garfien came up with the idea. They used a drop of fluorescent dye to simulate blood, and they dropped it into the water, and they simulated drug injection. And then at the very end, they turned on a black light, and what you can see is everything's glowing in the dark. So the syringe itself wasn't shared, only the water was, but everything, even the woman's hands, are glowing in the dark. Well, I thought I could just take this video and dub it and include it in my intervention. And what I was told when we piloted the intervention with female sex workers in both Tijuana and Ciudad Juarez, they said, this woman doesn't look like us. Like, she's white and she has no sores on her arms, and, she doesn't talk like us. Can't we make our own video? And of course, I hadn't budgeted for this, but they were very persuasive. And so what they came up with was their own script. And they shot this video in a shooting gallery in a picadero. And it was conceived of and featured women in the sex work community. And it was really powerful. And I don't have time to get into all of the results of this intervention, but the intervention was only 60 minutes long. It was 30 minutes for focusing on safer sex and 30 minutes focusing on substance use and in the context of sex work. And the intervention was associated with a reduction in both sexual and injection risks. And then, by this time, I was engaging in intervention studies and doing, more and more studies that were looking at predictors of incident HIV infection. And it became very clear that individual level risk behaviors were not the problem. The problem was structural. And I'm going to give you some examples of this. So for example, this is a recent study. I received some supplemental funding to study SARS-CoV-2 very early on in the COVID pandemic. And we found that 36% had evidence of SARS-CoV-2 antibodies among the people who inject drugs in Tijuana. And we didn't find any active cases at the time because these folks had been already infected for a while. And yet, of those that tested positive for SARS-CoV-2, just over a third had ever had a COVID test. So there were a lot of missed opportunities for identification and treatment, and even to allow people to self-isolate if they could. And as you can see, our HIV prevalence started to creep up, but interestingly, Hep C prevalence dropped. And we haven't come up with a really hard reason for this, but I do think it's likely to be survivorship bias, because our early Hep C estimates were from early 2000s, and this is now 20 years later almost, and there hasn't been any treatment at all for Hep C among people who inject drugs in this region. So we went on to look at what are the factors that are going to be independently associated with SARS-CoV-2 seropositivity. This paper was for both people who inject drugs in San Diego and in Tijuana, but the results for both cities were almost identical. So, when we looked at factors that were independently associated, you see that recently engaging in sex work or recent incarceration were both independently associated after controlling for sex, age, and race ethnicity. And of course, we learned from some of the early research done in other populations that brown and Black people are at much higher risk for SARS-CoV-2 for structural reasons that we're well aware of. But the relationship between sex work and incarceration was new. And this allowed us to really point at some policy recommendations. For example, sex workers, because sex work is illegal in most settings, they're not going to receive any government benefits for workers to stay home or paid sick leave, like those kinds of things. And also that there had been outbreaks of SARS-CoV-2 in jails and prisons, and that overcrowding likely led to a lot of these infections. And so there was an effort to at least in California, to reduce the burden of people in incarcerated settings, and to let some folks out early. But this definitely was not done enough. Also, with respect to incarceration, it poses special risks for people who inject drugs. This is some work done by one of our PhD students, Carlos Rivera Saldon, that was published in Addiction. And what he looked at was whether there was a dose-response relationship between the number of incarcerations and HIV infection, and also the extent to which it differed based on whether somebody was recently released or not. And you can see that the highest risk is three or more incarcerations and being released recently. But even those that had 3 incarcerations that were not released recently had an elevated risk. It was marginally significant. And so it really pointed to the fact that people inject drugs who are, harassed by police for carrying syringes, even though they're legal. It's driving people into shooting galleries where they engage in higher risk behaviors. They're afraid to carry syringes. All of these things are known, but incarceration itself can pose a risk because people are injecting drugs in jail or engaging in sex in jail, and they don't have access to condoms or syringes. So this led us to think that why are we in developing interventions all the time at the individual level when the problems are structural? So what we decided to do in this particular case was to develop a police education program called Proyecto Escudo, and Escudo means shield. And I partnered with Leo Beletsky, who has a JD and a degree in public health, and my colleague Gudelia Rangel. And what we decided to do was to try to align policing with public health. And Leo has done this kind of work in other settings, and he talks about bundling occupational safety messages with public health messages. And so what we initially did was a survey of police officers asking them if they'd ever had needle sticks, and 15% had. And many of these were recent, and there was no post-exposure prophylaxis program for these folks. So we actually set one up within the police department and gained trust. And then we proposed that we would develop this intervention and offer it through the police academy. And when we told the police chief that he wouldn't have to pay for it, he said, "Oh, this is great." And he said, "Would you even allow my police instructors to be trained so that they can give the training, and then we'll continue it if it works after the study is done." So we got NIH funding for this, and it was a stepped wedged design because we didn't want to deny any officers access to the intervention. And so we did this by class. So each class was trained in tandem, and then we chose a random subsample from each class of officers that we would follow over time to see how it changed their behaviors, at least from their perspective. But we knew that the police weren't necessarily going to tell us if they were doing things that were going to be putting drug users at risk, or even themselves at risk. So what we did was use my parallel cohort of people who inject drugs kind of as a external comparison group, so that we would understand from the people who inject drugs perspective whether their policing experiences were changing. So, this intervention was done, and it was a 3-hour course. It was designed into 3 modules: basic epi, prevention and treatment of HIV, Hep C, and TB. We also covered the fairly recent drug policy reform in Mexico that decriminalized small amounts of drugs for personal consumption. And then we inserted harm reduction, and taught them about, how they could refer people to harm reduction programs instead of incarcerating them. And then we studied to see what happened. Well, one of our postdocs, Javier Cepeda, was funded for a K award to actually study the impact in the people who inject drugs. And you'll see that this graph shows the incarceration rates over time in the months post the police education program, pre-PEP versus post-PEP. And there was a 21% reduction in the risk of incarceration for each of these 3-month periods post intervention. And that was highly significant. He presented this at the AIDS conference last summer, and it's currently being prepared for publication. And then we also did some modeling. And so we projected over the short-term horizon and the long-term horizon what kind of effect this intervention would have on HIV infections and overdoses. And so even though it was designed really to focus on HIV risk reduction, you can see that there's a significant impact on overdose as well, because policing behaviors, as I mentioned, drive people who inject drugs to engage in higher risk behaviors where they might be rushing their injection and putting themselves more at risk for overdose. Sadly, the administration in Tijuana changed, and they did not continue the police education intervention, but it is being considered in the U.S. now. So you can learn from Mexico in the U.S. Another lesson that I learned is the importance of binational partnerships. So the example that I just gave with the police academy was one such example, but one of the earliest ones came by mistake. And it's because we were trying to recruit and follow up people who inject drugs in Tijuana. And it's a very large city with streets that are very hard to navigate, and nobody has public transportation to speak of. And so what we ended up doing, I had a mobile van for my study in Baltimore that NIH had allowed me to purchase, and they allowed me to bring that van to San Diego, and we purchased it with some discretionary funds and donated it to the nonprofit that we were working with in TJ. Because I said, during the day, we need to recruit and follow up participants for our study, but during the evening, you can use this for needle exchange. And so that's exactly what happened. And this van was dubbed the Preve Mobile. So Preve is the verb to test in Spanish, VIH meaning HIV, and so this became a very popular intervention, and it never dreamed on me that it would catch on. So the health minister and also the head of SENCITA, which oversaw AIDS prevention and treatment for all of the country, they got excited by this, and they had a whole fleet of them made, and these are called condonettas. They're little Renault vans that are outfitted with a loudspeaker on top, and they would go down the red light district and go condones, syringes, just like the ice cream truck. So condoms, syringes, and they also had a TV screen in the back where educational messages could be played. And so pictured here is the governor of Baja California and the health minister at the time, with one of my project directors. And so this, one act of generosity ended up being something that affected every Mexican state got given condonettas, which is pretty cool. The other thing is that data that I showed you early on of the prevalence estimates for HIV in those subpopulations, even though it was just simple prevalence estimates, it was the first time that these estimates had been available for many of these populations. And it allowed Mexican colleagues to successfully apply for funds from the Global Fund to fight HIV, TB, and malaria. And in 2010, they had a successful bid and they got a surplus of $70 million. And that was used for harm reduction as well as other HIV prevention interventions. Sadly, those funding ran out because the Global Fund ran out of money, and also the devaluation of the peso played a role. And unfortunately, Mexico didn't plan for the ending of this. And so now resources are even in shorter supply. So it's one step forward, two steps back. But nevertheless, it did show the power of data to make a difference. It hasn't been all rosy though, because HIV care has been a big problem, especially in the border region. When we could think of the HIV care cascade, and we created it using data from all of our studies in Mexico. This is published by my colleague Laramie Smith. You can see that less than half of HIV positive people had ever been tested and knew their status. It was only 11.5% knew that they were positive. Only 11% of those were linked to care, and less than 5% were receiving antiretrovirals. This situation is still the same. It's abysmal. And we still had people in our studies coming to us for care. And of course, we're HIV studies that are funded by NIH. We're not there to provide services. So this is a huge dilemma for me because I didn't want to be turning people away. So what we ended up doing is creating a binational student-run free clinic, because we are a medical school at UCSD, and our counterparts in Tijuana at the Universidad Autónoma de Baja California, they wanted to be trained. And so we thought, well, there's a successful model in San Diego called the Student Run Free Clinic, and it caters to the unhoused population in San Diego. So what we did was we set up a similar program in TJ based at a nonprofit, and made it a preclinical elective for medical students. And so the medical students from UCSD and the medical students from UABC were actually getting trained side by side. And another benefit out of this is that the cultural competencies were gained in both teams, and we had preceptors from both campuses. So my colleagues, Victoria Ojeda and Jose Luis Burgos, run this program. And the benefit is that there's a triple benefit because people are getting free care and services. So I'm super proud of this program. And then lastly, I want to say that training goes a long way. Early on, we realized the benefit of having a training program embedded in our research studies. And it's had the benefit of training a number of people who are now assistant professors and associate professors at various schools, including UCSF. I didn't even have enough room on the slide, but Megan Morris is an associate professor at UCSF now, Jenny Jane, assistant professor, Meredith Meacham, and one of our recent PhD students, Christina Espinoza, is now a postdoc. Some of these folks have stayed in the US, but others like Claudia Raful have gone on to Mexico, and others like Teresita Rocha have moved to Chile. So we're kind of populating this model in various locations. And they've also, I'm really pleased that a number of their papers have been published in top journals. And they have gone on, to be, leaders of working with underserved populations. And this work was really funded by multiple training grants. At UCSF, you have T32 program, just like we do, but the T32 only funds US citizens and green card holders. And so we were able to get funding from the Fogarty International Center through an A-TRIP that would allow us to have a parallel cohort of mentees who were trained from Mexico. And so we could train people side by side. And again, that cultural competency, the training was bi-directional. And sadly, now Mexico is considered to be an upper middle income country and is not eligible for Fogarty funds any longer. I have been protesting this, but so far they've held their course. So hopefully that will change in the future. So I'll just close by saying that, I've learned an awful lot from my work on the Mexico-US border. It's been team science, and we've tried to face it with cultural humility. We have come to realize that social and structural factors are more important as risk factors for HIV and these related syndemics than individual level risk behaviors. And that really means that structural interventions need to be considered, because they can simultaneously impact multiple health outcomes if you're intervening on their root causes, and they can ultimately be cost saving. And then integrating binational research and training has multiple benefits, not just to the trainees, but I personally have learned more from my trainees than they have learned from me. When I, started doing this work, I had, just assumptions that had come from a naive place. I just thought, well, you're born in Mexico, so you must speak Spanish, but not necessarily, or vice versa. And so I've come to realize that how important it is for us to be open-minded as educators, so that we are able to learn lessons from our mentees, and not just the other way around. And that also there's a need to continually engage policymakers and non-governmental organizations on both sides of the border, because it's a very dynamic situation. For the police education program alone, we had to partner with 3 different police chiefs, because things changed so quickly during the 5-year study period. So it really shows the importance of continuity. So with that, I'll just say that our goal is to build bridges and not walls. It's been a challenging place to work, especially under the Trump administration, but we have had some successes. And I'm just really honored to have had the privilege of working with so many wonderful trainees that have gone on to do much bigger things. So I'll stop there and see if anybody has any questions. And here's some of our partners. Thank you very much.
Thank you so much for your presentation, Steph. It was really wonderful to see you today, and it was kind of lovely to take a trip down memory lane. I really love your work, as you know, and I'm wondering, we always talk about sort of how developing and designing structural interventions is so challenging, but that's what, is ultimately really needed. And so I'm wondering if you have any advice that you can share with this group on sort of like how to develop and design structural level interventions.
Well, I think it really depends on what level that you want to intervene on. With the police education program, we were, really trying to intervene, on the legal kind of, but also educational kind of level. There have been other approaches to try to intervene at the level of the couple. So, for example, we had a study of female sex workers and their intimate partners, and because we realized that many of them were partnered, and that was another assumption that I made. I thought it never really occurred to me that female sex workers would have be married, and that their partner would know about their work. So we have really tried to spend some time talking to the population at risk, and finding out what are the intervention targets that would make sense. So that one actually, turned out to be, important, because their partners were much more influential on them, and many of their partners were dependent on them for income. So, and it was only through doing qualitative, in-depth interviews with female sex workers that we learned of this, and that was informed by some of the quantitative work to show that over half did have partners that they considered to be regular partnerships. So that's just one example, but I think doing qualitative research is very important, and not just to decide how to do or what level of intervention, but also to inform the intervention over time and to conduct process evaluation. I think one of the big lessons that we learned from, from PrEP and some of the earlier studies is that, PrEP works if people take it, right? Well, like, why aren't people taking it? Like, some of that early qualitative research was not done. And to some extent, that was because it was funded by NIAID and not necessarily NIMH. And that's why those two institutes now work more closely together. So I think that, we need to be mindful of the lessons that we should be learning to inform, the next phase of structural interventions moving ahead.
Thank you.
Elise, did you want to go next? And then let's do Alex and then Steffani.
Sure, Steph, great to see you. Thank you so much. That was great to see just the trajectory of your work since you've been in San Diego, and you putting it all together just made an amazing story. So thank you. My question is kind of getting back to what you said a second ago when you were saying some people have partners who know that they're engaging in sex work. And as you were talking, I was thinking, I wonder if the type of sex work that people are doing is having, like, for instance, are they in an organized group, or are they mostly independent, or are they someone who mostly has established clients that they go back to again and again, versus someone who might go out a lot more independent, like the type of work they're doing and kind of the context. Was that having an influence on the HIV outcomes, and also just on how policing took place? Like, was policing impacting different types of sex work differently?
Yeah, with the sex work situation, it really varies a lot by city and sometimes even within neighborhoods within cities. So in Ciudad Juarez, there were whole buildings where women collectively got together and rented rooms, like in a group. And that gave them some solidarity. In TJ, there was nothing of the kind. But I think some of the best work that's been done in this area is from Vancouver, where they've been actually able to, have legal brothels due to a loophole in the policies. So, and policing, though, it really does change over time, because when there's a change in government, the local municipal government generally, then, what used to be, administration that embraced harm reduction can change overnight to become, one that's very punitive. And we're seeing that in Mexico right now. For example, naloxone, the president of Mexico says that it's irrelevant because there's so few people using opiates, but they don't even really have good estimates of people using opiates. And they closed down the only methadone manufacturing plant just 2 weeks ago in the country. So what that's going to unfortunately do is cause people to undergo rapid detoxification or cold turkey, and it's going to lead to people relapsing, et cetera. So I think that this is a long-winded way of answering your question, but looking for natural experiments where things are happening at the ground level organically, or where there's a policy change that could have unintended consequences, to be able to capitalize upon those, and to use approaches like time-sensitive oral ones or administrative supplements to examine it. And this is another digression, but your work has come full circle for me recently, because your early work, Elise, on syringe vending machines from Baltimore, remember that? There are now more comprehensive harm reduction vending machines that dispense naloxone and fentanyl testing strips. And so that is another level of intervention, that it's part of the built environment, and also has to have, policies that are supportive of it in order to work. So that's something that we're also now about to evaluate in San Diego. So thank you for your early work, because I just cited it recently.
Cool, thanks.
As has already been said, it was great to see the trajectory of your work, and thank you for doing such an important work. You may have said this, but I missed it. Did you encounter any male sex workers? Like in the United States, we have MSM who may trade sex for other things than money.
Yes, I myself wasn't involved in the study of male sex workers, but one of our mentees, David Goodman, did a study of men who have sex with men who were also injecting drugs, and there was a high proportion who were also trading sex, and their HIV prevalence was on this earlier slide that I shared, which I believe was around 20%. There's efforts also to work with the transgender community in Tijuana recently, because that population is even at greater risk and is doubly persecuted.
Thank you.
Triveni, did you still have your question?
Yeah, hi. I think you may have started talking about this, but I'm an addiction physician and do a lot of medical legal immigration work. And my question was about medications for addiction treatment, which you started to talk about. And just I wanted to hear more about access to those. You mentioned the poor access to methadone, but I wonder what are the next steps that are needed in terms of increasing access to medications for addiction treatment in order to decrease the risk of HIV and other infectious diseases that you discussed?
Yeah, it's a terrible problem because, even within the medical establishment in Mexico, there's a lot of non-believers. As you know, more than I, medications for opioid use disorder, like methadone and buprenorphine, are essential medicines, according to the World Health Organization. So it really is a human rights violation to deny or to withhold MAUD, especially from people that have been on it. So I think that the intervention is going to need to be actually at the policymaker level to change their attitudes and their knowledge. And I don't know that they're really open to doing so. But we're trying now to get other routes of methadone and buprenorphine, into Mexico, but there's importation issues. But aside from that, there's hydromorphone, there's naltrexone. I mean, there are other medication assisted treatments that could be used in the interim to bridge people. We know from 2014, when Russia annexed Crimea, 800 people who were on methadone suddenly couldn't access it because it was considered illegal. So these kinds of things, in Katrina, when it hit the southern U.S. states, it also made people who were on methadone have no access, and some moved to other states. Some Ukrainians took in Crimeans, but in Mexico, we have hundreds, if not thousands, of people who are on methadone who are suddenly being cut off. So it really calls upon us for advocacy, and I'm actually working on this alongside trying to evaluate its impact, because at some point you have to say, okay, research is important, but sometimes you just have to do the right thing. And when it's a human rights violation and people's lives are at risk, we need to take a leap of faith and say we have enough data to act, and let's do it.
I want to echo everyone's gratitude, Steph, for this fantastic presentation and just hearing about all your lessons learned the past 20 years. And I also wanted to ask a question about the HIV care continuum slide that you shared, and how big the gap is between the folks who are aware of their status and the folks who are on ART. And I feel like there's some parallels even here in San Francisco with people who inject drugs having low access to PrEP, and HIV infections not really decreasing as quickly as other key populations. And I wonder, in your view, what are some things that still need to be done in order to reduce that gap in the HIV care continuum for people who use drugs?
Well, one of the structural aspects of ART access in Mexico is that because Mexico falls under NAFTA, that they have to pay a higher price for antiretrovirals compared to other, lower middle income countries. So that certainly is an issue, but also the fact that the way that HIV medicines are actually dispersed in Mexico is through these centers, these clinics, and the one in Tijuana is very remote from most of the people who are living in, like, you know, the poorest communities in the Zona Norte. So it would be like more than an hour bus ride every day for somebody to travel there. And there's a huge stigma as well. So there needs to be ways to decentralize services and to integrate services. And I'm a big believer in mobile services, but you know, the condonetas that I showed you, even though you know they were you know, rolled out, I don't think it has been a model that has been sustained, and that's been one of the constant problems, is the continuity of care and services has really been interrupted over time. So it's been discouraging, I have to say, but I haven't given up.
Well, thank you so much. I feel like that's a nice call to action for everybody to keep fighting this fight and, you know, continuing to follow your inspirational lead and not give up. And yeah, I think I'm aware of the time. So with that in mind, everyone, please give Steph one more round of applause, and thank you for joining us.
Thank you very much. I really appreciate
Thank
it.
you.
It's nice to see so many friendly faces.